Good afternoon. Thank y'all for coming. My name is Susan Hayes. This is the TCUP Working Group panel. I am an attorney and the public representative to the Department of Public Safety's Advisory Working Group on the Texas Compassionate Use Act. And in the interest of time, I'm going to introduce everybody else on the panel real quick, and then we'll dive into it. The working group has patient representatives, licensed dispensing organizations representatives, and physician representatives. So I'm going to start down there at the end. That is Chase Bearden with the Coalition of Texans with Disabilities, who is one of the patient representatives on the working group. Next to him, we've got Liz Cross, who has a really interesting medical practice where she advises families who are in the cannabis program working with their treating physicians. And then we've got the licensed dispensing organizations. We got Kris Kem with FLUENT there, Nico Richardson with Texas Original, and we only had one of the two current physicians on the working group because the other one couldn't make it, Dr. Mike Gorby, who also brings an interesting perspective because he practices in Palestine, Texas, in a rural East Texas jurisdiction. So I'm going to start us off with, because many people don't know exactly what our medical program is because it's so small and obscure, what the compassionate use program is. It was passed in 2015 and requires reasonable statewide access. And I'm going to pop quiz the rest of us. Dr. Gorby, what all conditions are covered? I just got a blank stare.
Autism, epilepsy, cancer, incurable neurologic deterioration, multiple sclerosis, spasticity, PTSD, and
peripheral neuropathy.
You get all cancers?
Yeah, all kinds of neurodegenerative conditions.
Yeah.
There's like 4 pages of them.
not chronic pain. That's what you got to pay.
Yeah. And then Nico, any limits on THC in the program?
Yes, we have a cap of 1% by weight THC. So that basically limits what we can manufacture and sell into primarily edibles and tinctures.
And I'll bounce back to Dr. Gorby. Does capping by percentage make any sense at all?
No.
Okay.
No, we like milligrams.
And then Kris, who can prescribe THC or in the low THC program, medical program?
Sure. Physicians that have gone through a certain qualification process, or speak up. There are a number of physicians that can go through a certain qualification process through TCUP to have the ability to prescribe to their patients.
Board certified.
Board certified. There we go. And let's see. And I'm going to throw the rest of the questions. I'll let our patient advocates off the hook on this. With other restrictions of the program, who regulates it? Kris or Nico?
DPS regulates.
So the state police does.
State police.
Yeah.
Correct.
Is that a little odd around the country?
It's not common within the United States. There are a couple programs that are regulated by police. When you look up at other countries, it's definitely happened before. It's not without precedent. But a lot of times certain states will spin up a regulatory body specifically to oversee cannabis because it is pretty different, but not without precedent.
And as dispensing organizations, how many locations do you get to have?
Technically one by which we can carry our inventory in that location. So there's one licensed area, and then we have essentially satellite pickup locations across the state.
So you have to provide reasonable statewide access from one location?
We do. Yeah.
Right. Dr. Gorby, does that work for your patients in East Texas?
It's not optimal. I'm glad I'm not in El Paso, I guess, but some of them have come down here to Austin to pick it up. They can pick it up in Austin and Dallas and Houston and Nacogdoches. So,
yeah.
But if they have it delivered, I understand it's like about a 2-week lead time, which is kind of a problem because you got to time everything.
And for those who don't have a concept of where Palestine is, how many hours drive is it from Palestine to either Dallas or Austin?
2 to 3 hours. You could probably cover 3 or 4 states back east.
I can testify to that. Yes.
All right, I'm going to ask some medical questions. Chase, with the Coalition of Texans with Disabilities, you'll have members all over the state, yes?
Yes.
And what do you hear from your members about their ability to access the product?
I think for a majority of them, it's a difficulty because they can't always be at home when a delivery is going to be made. When they're being delivered, they have to be scheduled out. And there's only so much you can do to try and make that work. There's got to be more expansion in the whole program to allow that and allow access for those who are the ones able to distribute it in that safe way. But for a majority of them, if they're working or they're in school, or even like for me, when I was up at the Capitol, can't just have someone come traipsing in to do a delivery in the Capitol. That would just not look great. But I think access is one of the big issues for many of our members. And I think it creates a bigger expense in the whole program just to be able to pull off.
And Liz, most of your patients are children and their families. How about what issues do they have with accessing the medicine?
So of course, children need to have a caregiver who's able to go and sign for it. So they need to have a caregiver do those things. They need to be able to have someone who can drive, sign them up, tell them they're going to do, what they're going to take, administer it. And if they're in schools or other things, they have other loopholes they have to jump through to be able to get their medications.
And with school, what kind of loopholes do they run into to be able to get their medicine if they need to take it multiple times a day?
So luckily, we have made progress with this. I do spend some of my time educating the independent school districts about this program, TCUP in general. I go around and talk to the directors, and I let them know that this is a legal way to access cannabis in the state and that the students are able to take it. They have changed their policies at school that does allow them to have access to just the dispensary products. This is not opening up hemp to them at school. This is only from one of the 3 dispensaries. Once they get everything paperwork lined up, it has to be in their IEP or their 504 plan. They then need to have someone or a place for it to be locked up securely on campus. They need to have people who are registered and how to administer it. And then all those boxes are checked, and then they can actually receive their medication at school.
Does it have to be a school nurse?
It does not have to be a school nurse. Some of the school nurses are concerned about their own licensures, and they worry that they will actually lose their license if they give this in school. So instead, we have other administration people on campus who will say that they will give it because it's kind of the Good Samaritan clause, right? If you don't have a license to lose, you can't lose it.
So the math teacher may end up giving it.
So the math teacher may end up giving it. Yep. Vice principals, sometimes usually special ed teachers who see the benefit will give it in the classroom.
Wow. It's counterintuitive that would be the fact on the ground. And speaking of facts on the ground, we've got a market here in Texas that has a whole lot of consumable hemp products. And so with difficulty accessing products when the licensees are limited to one location for their product overnight, like Dr. Gorby, do you see your patients using hemp products in lieu of what they've been prescribed?
Absolutely. I mean, it's 3 or 4 years ago, I was just looking for another therapeutic option for my patients, right? I'm like most physicians, most clinicians, they just want to alleviate symptoms and help people find the best solution and live the healthiest life. But we're under that proverbial first do no harm,
Yeah.
And so I think I like using medical cannabis in people that it's not the answer for everybody, but it is at least I know it's pure and it's regulated, and I can't say that about anything else they get. So, but they're getting it, and there's a big demand for that, and so yes, the answer is yes.
And Liz, what about you? Are you seeing your patients use hemp products in lieu of?
So because it's pediatrics, I really stress the importance of good, clean, safe products. And so, no, I don't find many adult, caregivers who are willing to put cost or even location and pickup before quality for their patients, for their children. And so, no, I don't see that. But I do see that sometimes they think, if they haven't been educated well, that it's not just these 3 dispensaries that they're able to use. I have heard many people have left other offices and said, oh, well, I have a prescription. I went down the road. This place said dispensary. There's a lot of hemp stores in Texas that list themselves as dispensaries. They are not one of the 3 regulated GPS dispensaries that are approved. So they do not have the same quality product. So sometimes there's a misconception there. But no, my patients usually stick with the 3 that we talk about.
And how about your members, Chase? What do you hear?
We're very specific with them about staying within the 3 regulated licensees, mainly because when we started this long ago, it was mostly for children that we were working on this. And a lot of the medications they were taking were very significant, not just your normal aspirin or antibiotic. And we wanted them working directly with their doctors. A lot of times when they go through, and we do have members that decide that the products offered within the program aren't broad enough for what they want, and they do know the risk. So we always have that discussion. But at the end of the day, we wanted a safe, regulated program with guardrails so that it was being treated more like a medical product. And I think the way things are right now, I cannot tell a lot of our members what's exactly in every product. I'm sure there are plenty of great products out there, but at the same time, there's also kind of in an unregulated market, just as many bad products that can be on the shelf. So we make it a practice not to push people into the hemp market.
Got it. And talk about adverse events. And, cannabis has been used for thousands of years by human beings, but a lot of what is out there is different dosages or different combinations that might be naturally occurring, and everybody's body reacts to a product differently. So Dr. Gorby, have you had any experience with patients reporting adverse events from taking cannabis products?
From the dispensed cannabis products or the
Maybe something they got down the corner or from their buddy.
Yeah. The dispensed ones have been very safe. I probably have 100 patients, not much more than that. It's just a part of my practice, not the whole amount. But I've not seen any adverse events on that, except for maybe financial toxicity. But I have heard of stories of people just vomiting for hours after taking something out of the hemp store, and I'm sure their products are not. Some of them are probably okay, but there's no way of knowing, so I can't endorse that, and I'm sure some are contaminated,
And when this happens, it means your patients come report it to you promptly, or how removed are you as a caregiver from being able to figure out what actually happened?
Well, probably a lot of my patients aren't even telling me that they're doing that. I mean, unless I inquire, but and if they report that, I'll tell them I got a different option that is much safer, and I can regulate it. But I don't know. In my practice, it seems like the people that have the best effects are the ones that would never step in a hemp store. They're coming to me, and especially if they're naive to this product. I mean, I've had a few patients just think I saved their lives, or I got them off of opioids or benzos, and they're much happier. But it's not for everybody. It's just, I think it's a good option.
A tool in the toolkit.
A tool in the toolkit.
And anybody else, and this may be more directed at the patient advocates and dispensaries for now, experience with adverse events, and then what happens?
I think the biggest adverse event that we hear of mostly within the dispense is the amount of oil someone might have to take because there's so few options.
Oh, yeah.
On
I
our
remember you
side.
testifying about this once.
Yeah, is that GI issues because you're limited to basically inedible or oils.
With a lot of
Then-
filler oil.
Yeah, which is a lot of filler oil,
Yeah.
which is probably not great for your cholesterol.
Yeah. And that, to be clear, the filler oil is because we've got this arbitrary percentage cap.
Yeah.
So to get the milligrams you need, you're having to consume something your body doesn't need.
Create weight.
Yeah. That's uncomfortable to process.
And you said this earlier, but the way this medicine is dosed in our program is volumetric. It's by milligrams. The way we're regulated is largely by milligrams. They track the milligrams that we sell throughout the entire ecosystem. The law obviously sets it at 1% by weight THC, but there's actually no cap on milligrams per patient.
Right.
No other market has, right? If you're
Yeah.
in Florida, there's a cap on number of milligrams you can sell to an individual patient. And here, there's no cap. The cap is only as if they were, trying to legislate alcohol, right? And
Yeah, it's
try
kind
to
of-
sell light beer or something, but that's not how these medicines work.
It's a bit of, I described it as upside down and inside out regulation.
Right.
That it doesn't make logical sense
Law.
given.
Upside down law. I don't think that's the regulation. The regulations just fit into.
Having looked at regulations in other states, like medical patients can, even in adult legal states, medical patients can acquire a higher percentage or a higher number of milligrams than on the rec market, but that's under a doctor's guidance.
Correct.
That they're able to do that. And let's talk about the regulatory structure. And Nico and Kris, or either one of y'all, give us an idea of kind of month to month what kind of compliance work y'all have to do to keep the state of Texas happy.
State of Texas happy. No, I mean, essentially what we need to do is we need to stay within the laws that are applied towards us. And they are a bit more regulated than what we would see in the hemp market, which is essentially an unregulated market. And, DPS is tasked with monitoring us and making sure that we are compliant with all of these rules. We do have monthly visits from DPS to ensure that we're staying compliant, as well as they can pop in on a regular basis. We do have a number of reports that we submit regularly to DPS as well. And it's a continued communication back and forth, because there are so many laws and some of the rules that are somewhat up to interpretation that we'll need clarity on, just like in anything else.
Yeah.
And DPS is there to act as assistants to help us interpret these rules the way that they see fit, and to make sure that we're staying compliant with them.
And with that paperwork, what kind of, go ahead.
To add on to that, so every batch of medicine that we produce has to be tested internally. Then we have to potentially give a sample to the DPS so they can test it out of state at a lab that's approved by them and verify our results with their results. That's every single batch, not, we did a test last year and we're going to use that C of A for products that we're selling this year and next year, which is what we do see on the other side on the hemp industry. Every single batch. We also do internal tests on WIP as it's going through our process. We have to provide our manifest of medicine that we are producing and where it is in inventory to the DPS on a monthly basis. So they know exactly where all of our inventory is. And then they can come in and verify what our inventory is on the spot. So do an inventory check and see if anything's missing for diversion. So they try and create and I think they have done a very good job of creating a very safe system that is protected from diversion. I mean, that was initially the great fear of starting a medical cannabis program in a place like Texas that didn't have any regulated cannabis, was if you're going to have these medical licenses where everyone knows where they are, we have to make sure that they're incredibly safe and people aren't stealing product from them and selling it on the black market. I think, obviously roll forward 7 years to where we are today, and, we'll look at our delivery routes or our our pickup locations in other states, and we'll have medicine that we, have to bring to Houston in the morning so patients can come pick up, and then whatever's not picked up, we have to take it from our store in Houston and drive it back to Austin that night. So we're constantly shuffling inventory back and forth. Now, that probably made a lot of sense 7 years ago, but you fast forward to today, and we pass on that route probably 700 hemp stores that are carrying the same products and just leaving them out. No cages, no safes, no all the stuff that we still comply with and work with, because that's the letter of the law, but it's also the intent of the law here in Texas. Because if you're selling intoxicating products, they have to be held in a safe location. So yes, it's a little frustrating and infuriating, but I also don't point that blame at our regulator, because they're doing their job based on what our law is.
Yeah.
I look at the other side and say, come on, give me a break. I mean,
Yeah.
there is letter of law, there's intent of law. And if you're not going to abide by either,
Well, and I think about
you're creating chaos.
the motivation of avoiding diversion might have made sense in 2015,
Doesn't it?
but that patient in El Paso just has to drive right across the river and to a legal state in New Mexico and can purchase whatever they wish. Or every single Texan coming back from skiing in Colorado, or what have you. That since we're now surrounded by states that are either legal or next to legal, are getting there, diversion's kind of a silly goal.
I think even that's fallen off now, which is if you go and talk to the recreational dispensaries in New Mexico and Oklahoma's medical market, even those border towns that were on, Texarkana and areas right on the
Trinidad, Colorado.
Those have fallen off dramatically.
Yeah.
So
Yeah, I could see that. I think a few years ago, we went through Trinidad and counted, which is right on the New Mexico border as you drive down toward Texas, over 20 stores, and now there's about 3. From just including the giant one that was right on the state line.
and to your point, if you're a medical patient in El Paso and it takes 2 weeks to get on one of our delivery schedules because we can't keep inventory in El Paso, it's just it's not allowed, but it's also not feasible. Are you really going to wait 2 weeks to get your medicine from the CUP, or are you going to go to the hemp market, or are you going to go over the border into New Mexico and just buy what you need there?
Yeah. To all the cannabis stores that are right by the horse racing track. Yeah. And I mean, there are a lot of gaps, and naturally as any time when you write this legislature writes statute and the agency comes in and writes regulations. And then when you actually start a program, lots of questions come up. So you'll have to turn to DPS for guidance of, how do you read this regulation, or what, this issue has arisen. Let's talk about how to best resolve that. I mean, do you all find yourselves having to ask DPS for guidance pretty regularly? And how does that communication process work? Are you getting answers back in time for you to make the business decisions you need to make?
Good.
I think the longer you're in this market, obviously when we have periods of change around legislative session, legislative change, it creates a lot more need for communication and trying to figure out how that new legislation impacts regulations. And there's a lot more communication around that. I'd say over time, we've gotten in a pretty smooth cadence on many things, right? So if anytime we want to release a new product, a new form of medicine to our patients, we have to get that pre-approved by the DPS. It has to go through a new testing regimen. And then once it gets approved, it goes out to market. That's a couple week process, a 2 to 3 week process. And that, makes total sense. More complicated things take more time. And that also makes sense. We're going to transition a license to a new facility and expand that facility and have to have some sort of overlap. That can take some months to figure out, and understandable. But that's the nature of having a highly regulated industry, and you work with that. So let's flip to the other side just to make a point of comment and reference here? Okay. There's a complaint at a hemp store about the products that are being sold there. And so those products now need to be spot checked and tested by dishes. How long does it take dishes to get around to testing that product at that hemp dispensary?
Last I heard, they were working on getting up to 12 people to police 8,000 or 9,000 stores.
Yeah. So
you've got
in their
a lot less frequent.
in their testimony in front of the State Affairs Committee, it was 5 years is what it would take. 5 years. So timeliness of communication with your regulator is important, and it's something that we all work on. And I think we have a good working relationship back and forth. The complete and utter lack of enforcement and regulation on the other side is unacceptable. It's just unacceptable.
Got it.
And I would say one thing, I think it says a lot that DPS is here.
Yeah, that's right.
Attending the conference. I think that's an important thing, that when a state regulator stays involved, even within the community and where the discussions are going. So, even though it's not always easy, and I wouldn't say they had an easy task in this at all. I think that those steps of making sure those working relationships stay in place are important, especially leading into a legislative session.
And where's dishes?
And dishes of none.
And how do you?
I learned this morning that we do not have a robust medical cannabis program in Texas.
That's true. I'll say. Yeah, I do notice whenever I see charts of the country and what states are legal or medical, Texas is always left off the medical list. And let's talk about like fees. And it's sort of infamously, as this program was rolling out, there was one point where fees of upwards of $1.3 million were proposed, and the state cut those back. But y'all tell us, what fees do you have to pay every biennium? Because I know it's one in 1 year, one and a second amount in year two.
We just paid to renew our ability to continue to do business here in Texas. But again, this kind of goes back to what Nico's discussing is, this is part of doing business in a highly regulated market. And ultimately, and I know Nico's in agreement with me here for the most part. I don't want to speak on your behalf, but we're more than willing to accept, the fees, the regulation, and everything that comes with it. And we understand that it's not an easy market to regulate. But what we're looking for is, you look at going back again to the illicit hemp market, it's almost nothing to enter that market. And so, they're coming up with a head start right there with their stores, with their lack of fees, lack of oversight. It's really not about the fees that the cost that we need to incur. Sure, it's a cost. It's cost of doing business. But that cost of doing business is that there's a reason for it. And ultimately,
You need to fund a regulatory body.
exactly.
That's the give and take. So on our end, is it $400,000 every other year now?
Something about
It's like $400,000 every other year for a license. And every single person that works for you, we have about 100 employees now, 90 something employees, is $500 to get their CUP card. And then it's an annual renewal. So you pay $500 every year per employee. So that's how we fund our program. Dishes, how they fund their program. What is $7,000 per license? Something like that?
No. On the hemp producer side at TDA, it's $200 per.
Yeah.
But we're talking a couple $100 versus thousands.
And what is it on the retail side?
I believe, I'm doing it off the top of my head. You're spot checking me. $100. Anybody else? Something different?
150. So
50.
that's how you fund your regulator on the other side. So it creates a perverse incentive of issuing a massive number of licenses, 7,000 licenses. You cannot regulate 7,000. It is not possible to regulate 7,000 licenses.
Well,
And
to regulate them well. To regulate them well.
to regulate them,
Well, but ask the alcohol industry that. They've got
how many
1,000
liquor
locations,
licenses are in?
and I don't know what their fees are for a liquor store or if you're selling beer, but that's a really matured system with a big agency overseeing just that.
Is there not a tax on alcohol?
There is also a tax on alcohol.
So that's how you fund it in
Yep.
the state. There's no
Plus
specific
licenses.
excise tax on hemp products in Texas. So there's no additional funding coming through that.
Yeah.
And so you have 5 or 6 people that you're supporting to go, you cannot, it's not possible.
And Texas really likes doing what I think of as user fees, where they're not using general revenue to fund a specific program. When you pass a bill through the legislature, you get what's called a fiscal note. And if your fiscal note is going to cost the state money, your bill ain't going to pass.
Yeah.
So programs tend to be self-funded when they're created. And as if I recall some years ago, when there was a legalization bill, it had a positive fiscal note of several million because they thought there would be thousands of locations, plenty of individual businesses to pay the fees, and then that would fund the enforcement of it and still get the state back money. And of other regulations you guys have, are there any that stick out that in terms of your cost of doing business have a disproportionately high cost for what looks like the value to regulating the business and keeping it safe is? You get the idea.
The one that jumps out is probably inventory storage. And that's been an issue we're trying to drive forward over time. You know,
Meaning having
overnight
good-
storage.
being
just
able
like
to
placed
keep
overnight.
being able to keep working inventory, finished goods inventory at the locations where our patients are and being able to issue those prescriptions there. If you go to Walgreens or CVS, they do often have to ship medicine in, but they're not typically shipping all of the medicine after you order your prescription. You can walk into one of those locations and they can bottle it for you on the spot.
And when you're shipping that and taking it out of your secure environment into a car, that seems to be a counterproductive way to keep the product secure.
Yeah, I
If it's having
certainly
to
don't
move
think
in a
it's
vehicle.
safer,
Yeah.
but
Okay.
been working on it.
All right. I'm going to talk about the chart that the fabulous Heather got up online. We talked about this before, and I failed to make sure it was going to be put up. So thank you for making that happen, Heather. And I mean, this program has been around. Well, original law passed in 2015. So going on 10 years since the law passed. The first the only licenses were selected in 2017. And I think Compassionate probably got operational like in 2018. So we're several years into this program. DPS publishes on their website a patient count and a physician count. And now after more than 5 years of a program, the patient count is still under 100,000. And this is data that was acquired through an Open Records Act request.
But that's not actual patients. It's far lower than that.
Okay, and let's walk through it because it's hard to kind of understand what we're seeing, and then we'll have people jump in on this. And this is reflective of new patients coming in. And what's striking about this chart the first time I saw it is you've got unique patients with a prescription created by month for several months. You see numbers varying, 4,200 and change, December, 2,900 and change. Look to the second column, unique patients with a prescription and a fulfillment, meaning they got into the program and filled a prescription. And let's just take the first one, September, over 4,286 patients, but only 2,847 actually filled their prescription. So a lot of patients are signing up for TCUP, but they're not buying from the dispensaries. And here, let me throw a loaded question out there. Why do we think that is? What's going on?
I think
Patient advocates, what
I
do
think
y'all hear
there's-
from people?
I think there's multiple reasons. I mean, I myself am no longer on there.
Yeah.
Over the years, with the limited amount of products and what I needed, it did help me to come off of being on opioids. But, it's gotten to the point where for me, getting it picked up, the amount that it was costing, and it just not being the exact right thing that I needed, I moved back towards going back to my doctor for more of a kind of pharmaceutical fix on nerve pain. And it's not the medication I'm taking isn't an opioid anymore, but it's definitely not better in the long run. But over time, I think this is what's happening to a lot of our members is that they're leaving it or they're getting their prescription and then just going to the store that they see on the drive-in and don't fully understand the program and what's being offered. And they walk in and they pick it up at a hemp store, not knowing the difference. So there is also a lack of education. But I think at the end of the day, it's an access issue, and families, especially with kids with disabilities, they're doing PT, OT all week. They're dealing with other issues. Trying to make time to actually pick something up doesn't always work. And, most people would say, well, if it's helping that much, you would do it. A lot of people don't realize how much stress is on some of these families and what they're going through.
Yeah.
That they just don't have the time to do it. And I think that's where the disservice is playing. And my argument with the legislature a lot of times is that, this program was set up. And, and even talking with DPS, their motto is to protect and serve. I think our idea of this was to create a very safe, regulated program with guardrails. And that's the key important part of this, is that if we're going to do that, it's going to cost money.
Yeah.
And we got to have both industries being regulated to some point, or else there's a target, I think, across the board on cannabis if we don't protect the system as a whole and make sure that we keep it safe.
I recall because you and I both work around the Capitol and have worked on this issue for many years now. We once had a conversation about simple things like allowing drive-through pickups is so important to people with disabilities, because sometimes it's really hard to get out of the car and walk in there when someone's in pain. And they can do that with their regular prescription. So let's try, when we can finally get a good bill passed, to make sure that that's explicitly allowed. Dr. Gorby.
I would say that a small group of patients are on that list probably are people that are trying to normalize their THC use. They are subject to random drug screens or something, and if they pop positive for THC, they just want to go, hey, I'm in the database.
Right.
I don't know if that works, but that's
Patients who see it as a get out of jail free card.
That's a good point, though, that Dr. Gorby brings up. And while that's very much true, and I can attest to listening in on a number of calls in our call center, as well as making a number of these calls, it does go back to what Chase was saying. It's an accessibility issue. That's number one with a bullet. And what Dr. Gorby is saying is absolutely correct. And that is certainly a percentage of that, but it's accessibility. I have fielded phone calls myself from folks in Palestine or up near the Oklahoma border or way out in West Texas that'll call. They have a sense of excitement and a sense of hope to get into the TCUP program, to be able to access this medicine that they haven't been able to access previously. They give us a call. They want to place an order, and all of a sudden they're stunned with you're about 6-hour drive from our facility. And we'd love to take care of you. We're happy to do it. But we're going to have to get you, listed out to go when we're going in that direction and schedule it out. And unfortunately, I think there are a number of calls that we all receive that are, thank you, I'll look forward to that. And we call them back to schedule. We never hear from them again.
Yeah.
And I'm sure many of them have decided to go filling their prescription at the nearest dispensary.
Yeah.
In heavier quotes.
And I think I was just going to say, Chase is right. He's exited the program right now, but these numbers aren't exited the program. They got this month and just didn't fill. And so, to the credit, yes, it is access. It is being able to get to it. And it is somewhat people wanting to have a get out of jail free card to say, well, I'm in the program, that's why I have it. But there's also the cost. So a lot of times I get all the way through my visit. We've talked about everything and they're like, well, insurance covers this, right? No. Well, it does in California. No. It's a total they don't understand how this process works. And until this is federally legal, we can't have any insurance coverage. And I will say, to the credit of the DOs, they have significantly dropped the cost of these products to these patients year after year after year. So when I started in 2020, a 20-to-1, which is the only product we had, 20 part CBD, 1 part THC, was $350 a bottle. $350 a bottle. This was cost prohibitive. And it's now $80. So to put it in perspective, we've come a long way, but cost is still a big factor of these
And
numbers.
let's be clear, the DOs were not generating profit at $350 a
They're
bottle.
not.
The problem is lack of scale in
Yeah.
this program. That's right.
Yeah.
As we scale the program, we bring prices down dramatically. Like this is the path, right?
Yeah.
The best way to give good access to clean medicine to patients in Texas is to scale this program, allow us to drive through operational changes with scale, and it lowers unit cost down. And we've proven that year after year after year in the CUP, and we'll continue doing it, but we have to be able to scale the program. That's right.
And that doesn't show scale.
Yeah.
Yeah.
Regulation is
Yeah.
expensive. But I have many patients that tell me their receipt from the hemp store means it's legal. And, the cop that pulls them over doesn't know any different. I mean, or whatever. I mean, it's like they think they're buying legal product because it's got a license on the door and they sound very knowledgeable.
That's an important line of education. Yeah.
There's two things. So I actually think the biggest thing in this number, or the biggest thing that would drive this number closer to 100% parity between the two columns. And the number one thing people say when we talk to them and they ended up walking away from the program immediately is inhalable products.
Yeah.
So
And
they
let's-
call and they say, hey, great. Can I buy, a vaporizer here? Can I buy flour to vapor smoke? And we say, no, we have a 1% THC cap.
And
Hemp has a 0.3% THC
and
cap.
for anybody on the panel, why is inhalable important to patients?
It is a different pathway. It's a different delivery mechanism for the same medicine. So what the problem is, what the legislature doesn't understand is they've used the 0.3% language for hemp, and they viewed that as the bar by which to measure intoxication. And that is not how you measure intoxicate. You measure that by milligrams of THC, period.
Yeah.
And all that 1% does is force an edible pathway, which means THC, if you're talking about THC specifically, goes through your digestive tract, gets metabolized in your liver and turns into 11-hydroxy THC, which is a far more potent compound than Delta-9 THC.
Yeah. In fact, some states prohibited edibles at first.
That's right.
Because of that.
And I think something you can't remember or you can't forget, if someone's treating seizure disorders, an edible doesn't get you to stopping a seizure quickly. If it's coming on, if it's something, an inhaled product, we'll get into the system faster. It can actually help more. And it also lets you kind of regulate that a lot better than an edible in your system.
Yeah.
Yeah. So it's about
Titrate
onset
real
time and titrations, the patient being able
Yeah,
to control their
patient
dose.
titration versus
Yeah.
you eat it and you have to wait for whatever results happen.
Access to delivery, kind of a delivery mechanism that works for that patient's healthcare needs.
And that's the biggest problem is we need to get our government, get the legislature to understand that what we're not asking for is more potency. That's not what 1% to we'll call it a by weight cap to a volumetric cap means. What we need is another delivery mechanism for patients that have episodic conditions that need relief now.
Yeah.
And that's what we don't have. And so I think that actually is probably the biggest single factor that drives the difference between those two columns is we have a lot of patients that come in and say, okay, where can I buy this? You say, you can't get that in the CUP right now. And they say, okay, we're going to go to the black market or we're going to go to a hemp store that's going to sell me something through a loophole.
Or go hiking in Colorado.
Yeah.
Yeah. And let's talk about comparing cannabis medicine and then the kind of rules and regulations that we see in conventional medicines. And this came up when we were chatting the other day. And for anybody, when the FDA approves a drug for a particular use, what happens out there in healthcare world of how doctors use that drug? Explain those rules.
I think we were talking about semaglutide, right? Ozempic.
Yeah, well, this was about getting other sources where I think you brought up semaglutide.
Yeah. Because there's clearly a demand for cannabis that we can fill at times in our office, just like there's a demand for Ozempic, which is, the TikTok drug. Everybody wants it. They want to lose weight. It's a great diabetic drug, but it's expensive and it's made by one producer. And so there's black market Ozempic. I don't know where it comes from, but people are going and getting it. I mean, I can't tell them, to do that, but I'm sure if they were selling it out of vending machines, they'd get it that way too. That's probably next. So we want our goal is always to help patients, but I'm not at the risk of potentially harming them. And I guess if I do this long enough, I might see some harm from cannabis, but maybe you got to be careful with some psychiatric patients, and cannabis use disorder is probably a thing. But in my experience to date, I just haven't seen that. But I guess the black market or the gray market, you're calling it.
Gray market or black market
is not unique to cannabis, but it certainly
shows up with blockbuster drugs.
Yeah.
And then let's talk about notoriously dangerous drugs out like OxyContin. Nico, you had this comment. What conditions is OxyContin limited to in the healthcare?
Yeah, it's not written into, you leave that to your doctor. Under do no harm and let the doctor figure out the dosing. And there are, obviously there's liability associated with prescribing anything, if you do it incorrectly, but cannabis should be no different.
But your doctors are free to make the choice to do what's called off-label prescriptions. Yeah.
I think some of it's
sort of what problem you're dealing with. Cause like we all survived the COVID times, and there was a lot of drugs coming out and we were sort of we were using them in real time, trying to figure out if they worked or not. But I'm certainly no expert on cannabis. In fact, the amount of clinical chemistry just presented by Dr. Russo and Dr. Z just blew me away. It's just like the proverbial taking a drink from a fire hose. But I think our patients expect us to know more than the guy in the vape shop or themselves, and to advocate based on that knowledge and the knowledge of them. And that's, as long as I can still do that, I'll be happy.
Yeah. And I don't know, I've got one last question for y'all, and then maybe we'll have a few minutes for questions from the floor. Any success stories you want to share?
I think
Liz?
you might be.
All right. So I could probably fill this room with parents who would be here in a second if it meant that this kept going. Their biggest fear is that the DO is shut down, that this falls apart, that the hemp market takes over, that they're not able to keep their license going because they just don't have the patient numbers, right? If they're not being able to turn profit, they can't stay open for my kids, right? My pediatric patients do not make up most of their group. Let's face it, it's adults, right? But I have so many patients, mostly autistic. I also treat epilepsy, but my epileptologists usually do that themselves. It's usually the ones that come to me are more behavioral, spasticity. And the behavioral ones are the ones that are the parents would fill this room. They quite literally, I have story after story, but I'll pick one or two. I have one mom who brought her 18-year-old son to me. He's 18. He's nonverbal. She's always just cared for him. They have their own language of sorts of what he needs and how she cares, et cetera. She started CBD, something she heard of, and she thought, well, why not? We'll try it. First visit, we just did the education prescription, came back on the second visit, and she just said, I met my son for the first time at 18. She says, I now know him. I know him as a person. I know his personality. It has come through. She says, he is a different person. He has unlocked something. He's able to actually relate to me, relate to things in the room. We think about some of the diagnoses of the symptoms of autism where they don't play with a toy like a toy. You give them a car and they don't roam around and they spin the wheels, right? It's that kind of stuff that he stopped spinning the wheels literally and was like, oh man, it's a car. Want to play cars? And started interacting with someone else in his environment, which was huge. Another play story, I had a probably 8-year-old. He and his younger brother showed up at the same appointment. Mom was in the room, 2 boys, 8-year-old. The older one is the one who's the patient. The younger one, annoyed mostly by his 8-year-old brother. Too much behavior, too out of control, just too much. The little one is on his tablet and says, can I not be in here? Like this brother is too much for me. And his mom grants him permission to sit right outside the door. So he sits outside the door on his iPad. We have the whole visit. We decide, this is probably my third patient ever, which was my big moment too. And we decide to start CBD. She comes back a month later. The door is closed. This is before COVID. The door is closed. I knock on the door. I come in. I expect the brother's not with them because he's not outside the door on his tablet. And instead I walk in. They're both playing Duplo on the floor. And she says, she's like, he has a sibling. He has a brother again for the first time. And, you know, those are bigger examples where you've really brought families together. But I have story after story. We went on our first vacation. We were able to go to the grocery store after school. I mean, that doesn't sound like anything to most of us, right? But for a lot of these families, they are terrified of that meltdown. They're terrified of that event that's going to happen at the grocery store. That's going to be the police is called. It's a whole thing. And the next thing they know is they just stop going. I had one the other day who says, I Kroger and Walmart order everything. It's Amazon, Kroger delivery to my house. They said, I don't go anywhere because I'm so fearful of what this could turn into. And so those are the stories that keep me coming back and keep me and my patients here. And some of them are more moderate, of course. It's just he sleeps really well now. He doesn't wake up. But the big ones are really, really impressive.
That's great.
That's great.
Well, I and my two nurse practitioners, I think when the FDA reclassified hydrocodone as a Schedule II, we had probably over 200 patients on chronic opioid therapy, and now we have 20. And the ones that had qualifying diagnosis have transitioned to cannabis, and they feel better. They're happier than they were. But if you got cancer, you could have all the hydrocodone you want. Well, not all the but other drugs. It just seems to be a much better solution. The last patient I saw yesterday was a young woman who has stage 4 breast cancer, but her oncologist suggested she find somebody that can give her cannabis. And I guess she Googled and found I'm in East Texas. And I haven't seen her back, but I have a feeling it was mainly her nausea and vomiting and a little bit of pain. And I think she just doesn't want opioids, and she's going to be better served by this product.
Well, I'm putting those numbers in context in my head. I mean, because you're a country doctor, you've got a really broad practice, and I'm familiar with the county where you live. I spent a lot of time there.
Help my wife get elected.
Yeah. And I think you said you had about 300 patients, 200 of them, you've gotten all but 20 off opioids.
Well, yeah, but that's not all.
But
some of them,
that's
they have to fulfill the FDA requirements now, coming in monthly and having. So some of them, I don't know, may have been diverted. I don't know. They just. It used to be pain was don't have anybody in pain, but chronic pain. Opioids are not the drug for chronic pain. Cannabis is the right drug for some patients. And I like to use it as a drug. The more I understand about it, the better. I think I can serve my patients. As long as you guys stick around.
Yes. It's not a silver bullet.
Yeah.
But it is a really good tool in the toolkit for most doctors. And they should be able to prescribe freely based on that because of the safety profile of this product.
And I would say, I think many of us are very protective of the program and want to see it flourish. Mainly because I know all those early times when we sat in hearings and how many parents I had come to me with kids that are dealing, my life is easy compared to what some of these kids are dealing with. And how many of them were willing to go up and testify. And I would beg them not to. Because the moment you get up to testify and you sign that you're going to testify and you talk about giving your child cannabis of any sort, there's a big difference between them doing that and me getting up there and saying, I drove to Colorado, picked it up and drove it back. That's a crime back then, but one that even if I mentioned and testified to, it's not something that I'm going to get a knock on my door and get drug out and taken to jail.
And your kids
A parent talking about something that has improved their child's life, help pull them off medications, giving a brother or sister back, would end up with a visit from CPS and probably lose their child. And let's face it, the state does not do a great job of taking care of most children, especially children with disabilities. So you'll probably, when you see a lot of us kind of argue and really push on this, it's why I feel like each side needs to have regulation of some sort, so that we don't end up with a target on the whole cannabis industry's back. I think it's something that we all, self-regulation is one thing, but we need to have a strong system that allows people to get access. For me, at the end of the day, I will protect all the kids that are benefiting and the parents from it first. Then the rest of us will be the ones benefiting in it. And if all of y'all can make a reasonable profit at the same time, I have no problems with that across the industry. So at the end of the day, it does change people's lives, but we need to treat it like a medication, and we need to make sure that our legislators and our regulators understand it.
And then you raised another issue that Liz alluded to earlier. We don't have protections in our law for people who are helping a patient or consuming cannabis themselves within this program. So we have the absurdity of the coach instead of the school nurse giving a kid their medicine because they don't have a license they can lose. And then a parent risking visits from CPS because their kid is in TCUP. And that's still a problem. I get, as an attorney, I get random calls from people who've had that experience and are trying to figure out how to navigate through it. Yes. And
it's not necessarily true anymore as far as the nurses. I am a cannabis nurse.
Mhm.
And in September of 2023, they recognized us as our own specialty. So no.
I'm talking about school nurses.
yeah,
Tell them, hey, you're your own specialty now. There's a course you can take to get your certification. You're right on board. And
Yeah.
when that fear will go away, because that's what our big fear was in Texas, was that the BDDs would come after us.
Yeah.
And because so we didn't really say anything, to say a whole lot. But now that we have the American Nurses Association that has given us our own scope, we are allowed to talk freely about it and proudly about it. And most nurses around are like, seriously? There's a cannabis nurse? And so that's
It's true. It's the Board of Nursing who hasn't made an official stance. And because they have not made an official stance, many of the Texas nurses are concerned for their license, and they're nervous. I mean, this is what I do too, is I go around and educate, but I ultimately say, I'm not pushing them to do something that they feel is illegal. If they are against it or they feel it's illegal, I do not push them. I tell them that it is within their scope, but they have to make a medical nursing decision to make that decision for themselves. So they are allowed to give it in school. I tell them that, but I don't tell them they have to give it in schools. That's what I've said. Sorry if it was misconstrued.
assisted living like that. It's assisted living, it's private pay, it's not federal money that pays the assisted living. Yet they won't allow us to even give CBD products in assisted living. As their own family member has to come up there.
Yeah.
They definitely are not going to do the nursing home because that's federal money.
Yeah.
But in assisted living, it is private pay money and they still won't buy it.
Yeah.
So that's where
Explicit protections would go a long way.
That one has to do with the legislation that's written around our bill here in Texas that governs the CUP. And part of that problem is it's very murky as to what a legal guardian can be. And so certain assisted living facilities are okay with that. And certain assisted living facilities are not okay with that.
and I could go to Texas like office.
Mhm.
That's where I'm coming from. His town's a little bit bigger than mine. So when I say, and this is the bubble mentality.
Yeah.
Yeah.
Bubble.
Yep.
And we don't want to take outside education.
Sounds like Texas as a whole sometimes. It's a big bubble.
Right. It's more, are we done, Heather? We have time for one more question. Okay. There's
When do we expect to see more diagnoses added?
Conditions?
They have to be at
And the
legislation.
question is, I'll repeat it so they're going to mic and have a loud voice. When can we expect to see more diagnoses added? And I'll jump into this one. And I have always thought conditions is just dumb because you know what? Legislators aren't doctors. Dr. Gorby's a doctor. He should be able to decide what's best for his patients. But Texas, like a lot of states, fell into that game early on. And we're still doing it long after other states have abandoned it. It's about getting the bill passed, and the choke point continues to be the lieutenant governor. And we have been able to get other conditions added over the years. And I mentioned this in a prior panel where I was subbing in for another lawyer. You know, we got seizure disorder added in that whole laundry list only because a Dallas Cowboys son had a seizure outside the Senate gallery. And that enabled some of the top senators to be able to convince the lieutenant governor to let the bill through. So being able, what I'd like to see is let's just let doctors practice medicine and get rid of the condition list altogether instead of continue to play the game of, well, we're going to add pain this time, but not something else. And I'm sure y'all have seen this in your practice. And earlier I saw a young Aggie who I know who has Tourette's, but we couldn't get Tourette's added to the bill that session, even though her father was there all the time telling the story of his family. Well, guess what? She's PTSD from all those trips and months at Texas Children's. So she got in through another condition, but really to treat her main issue, which is just dumb. We should be upfront about it. So I hope this next session is an opportunity. Everyone is, but we'll see what happens come Memorial Day.
We're hopeful. If you remember 2 years ago, we had HB 1805 that passed the House 127-19. And for whatever reason, it got put into committee in the Senate. I think it was the State Affairs Committee, but never got out of committee before Senate and House started shooting hostages during the session. So we were one of those hostages. But this is not a shouldn't be a contentious issue. It is not a partisan issue anymore in Texas. This is bipartisan. 127-19 in the House is basically unanimous at that point. And Senate, we would have had supermajority if it had gone to the floor. And that was for chronic pain in lieu of opioids. But frankly, it should be chronic pain. It should be sleep. It should be anxiety. It should be,
It should be what the doctor ordered.
It should just be either issued by a medical body or allow the doctor to make the call.
And it would be key if we could get to the point where we can allow the state agency to have more flexibility so that we can adapt to, changing market, how things are working. Because right now they're kind of have their hands tied and we have to wait every 2 years. Then we have to get something passed. Then we have to try and implement. Now we're 3 or 4 years out. And if something doesn't get passed, now you're 6 years out. So, making sure we build in flexibility so that we can serve people.
Yeah, the market and the science are changing a lot faster than the legislature meets.
Yeah. Thank you.
Life on a slippery slope.
And we got a question over here.
Station that is happening flower here in Texas. And not only flower, but are you all looking at other methods for medicine? Like when my best friend was going through breast cancer, she couldn't swallow. So eating a gummy, rolled in sugar, tincture, So we were using like the patches, to help transmit that oil through. So I'm just wondering, is that anything?
Part of that, yeah. Again, we're governed by that 1% by weight. And so when you deal with the patches, you're dealing with a high percentage THC concentration that's on a 3M patch that goes transdermal. Same thing with sublingual, which would have helped her. You have to have higher potency in order to do anything that's going to cross in the blood-brain barrier that doesn't get ingested through your doesn't get decarboxylated in your liver. So that's our problem. We need to get rid of the cap and change it to a volumetric cap, meaning a doctor can write X doses. This is what a medical dose is. If you want to put caps for a monthly basis or a 6-month basis on what you can sell to people, if you're worried about diversion, which we don't have right now, frankly. I mean, we don't have any caps on how much can be sold under the law. Then you can do it by methodology. I mean, Florida has their entire medical system regulated that way. For inhalable products, it's X milligrams per 70-day period. For edibles, it's it's Y milligrams for 70-day period, and so on and so forth. But you have to take a science approach to this, and you have to understand what the medicine is that you're regulating. And that, right now our law is not written that way.
And I'm going to argue with you even on caps. We don't need caps. We might want safeguards that higher
Safeguards.
doses
Yes.
are more restricted for diversion reasons or theft reasons, but that physicians ought to be able to prescribe what they believe is correct for that patient, because some patients need much higher doses.
Correct.
Answer
And
me.
that is absolutely correct. And I'm not trying to say that
Yeah.
there should be a end level cap on this. I'm saying that
I'll think of a simple example that, ibuprofen.
Yeah.
You can buy lower doses over the counter, but you need a prescription for higher doses.
yes. Yes.
Yes, ma'am.
Heard a lot about kind of the catch-22 of Texas, which is even if you're in the program, even if you're able to get it and you're able to afford it, how many people do you hear about not doing that because of their employment?
Yeah.
Because it's still Schedule 1 employers. They don't have to recognize that somebody is in that registry.
No.
If they drug test and test positive for THC, it doesn't matter if you have a prescription if they don't want to accommodate that. And so it seems like people are having to choose between, do I want to treat my symptoms or do I want to have a job?
And there's no easy solution on that one. And even in states that have gone.
Repeat the question.
Okay, I'm sorry. And the question is about people who, because of their employment, cannot even get into the program or use the product because of restrictions in their job. And my quick answer is there's no easy solution. As cannabis has been legalized around the country, one carve out has been you can still be fired if you're a truck driver and you've got THC in your system because of don't want impaired people. But what about employment where who cares if you're impaired? Even if you are, you're not dosing yourself. And a case just came out of the Fourth Circuit on the East Coast where a woman was fired. She wasn't in a medical cannabis program. She was using hemp products and using them for a medical purpose, though, for anxiety, and got fired because she tested positive for THC. And she ultimately lost the case because, you know what? Employers get to have those policies if that's what they want to do. So there's no, and what was interesting about that case, if I go a little lawyer nerd, is North Carolina had this old law about you can't be fired for using a legal product, which had to do with tobacco. It was passed long before cannabis came out. So her argument was, this is a legal product I'm using. But the court said, sorry, they still get to do that as employers, is have a reasonable policy about keeping drugs out of their workplace.
And I think even for employers who do allow people that are part of this program to use those products, but they also need to make sure that other people aren't coming in impaired and they do those drug tests. How do you tell the difference between somebody who is part of this program and somebody who's not?
Yeah, exactly. And another problem the employers have, and I tried and failed to negotiate with an employer for an employee. And I mean, their concern was, what if he's in a wreck and we get sued?
Yeah. Insurance.
Insurance,
insurance.
all this other things in the larger legal ecosystem are making it all but impossible to allow people to use cannabis products that help them and keep the job they want.
And also, if you have an employer and it is allowed, but the person is acting impaired, it could be too taking any kind of medication, is that, that employer probably ought to have a discussion with the person and they ought to come up with a solution on it. But, being impaired at any time, you should probably be balancing that and how you take your medications. And like on the side of your prescription bottle, don't operate heavy machinery until you know how it affects you. The moment you get your first prescription, don't go to work and take it.
And I'll go back. One thing little possibility that case raised is that the employee had not asked for what's called a reasonable accommodation. So if she'd walked in the door saying, I take this for anxiety, it really helps me be high functioning, but I just want you to know there's trace THC in this hemp product or this medical cannabis product, there's plenty of THC in it. And there's some argument that federal law would force them to accommodate her. And she had a desk job. You know, she wasn't operating heavy machinery. There wasn't a chance the company got sued because there was an accident.
It's worth it.
I'm sorry, the case law that I've read, it has, really emphasized that I don't think in Texas we would get the same result. Because again, it is a Schedule I, and so a lot of the case law is saying, well, you're not required to accommodate with something that's illegal, especially if there may be federal grants involved.
And also Texas has the most conservative federal circuit in the country. And the Texas Supreme Court is very conservative, but so is the Fourth Circuit. And that opinion kind of opens up a few windows.
And I'll add, I actually have written letters for my children, teenagers who are looking for their first job because their parents are worried about that first drug test. So I have written letters that say, this patient is under my care. They've been under my care for X amount of time. They've been taking this type of TCUP, CBD THC product. Please understand that they might test positive. We're just upfront with them about it. And if they already from the beginning say, well, you can't have the job because of that, then that's already out in the open and they're not getting fired from a drug test later on. Now, I can't guarantee that they're only using that, but most of my kids are.
I've also had people go and when they wanted to get into the program, go talk to HR first and say, look, this is something my
That's what you're going to say, yeah.
National Body Firm, which is the National Body for Management of the Nation. They kind of set they had the certifications for human resources. They are fighting this on a day-to-day basis. They don't know, if the headquarters is in California, but you work in Texas, can you pop positive in Texas, but you don't pop positive in California? It's an ongoing battle, not just the Texas rules. The whole nation in the HR world. They have the brain look. I don't know because it constantly, they lost the case in North Carolina, but that same case in South Carolina, they could have passed. Depending on the HR, like you said, the ADA, the reasonable.
Yeah, reasonable. And the other piece of that case where the plaintiff could have made a stronger case is they didn't have evidence of what was the Delta 9 level in the product. Was it hemp or not? Yes, ma'am.
Nico, with the dispensary, with your operations and dispensaries, you have so many things to overcome. If we were to change things in the legislation, it would be eliminating or changing the cap or changing it to milligrams instead. It would be improving access. It would be allowing additional methods like smokables and then addressing the unregulated market as a huge competitor right now. Well, so we talked about access of it. If these things happen, would additional dispensaries be built? Are there any bills in place that are like current legislation that's starting to be proposed?
Under our legislation right now, there can be 12 licenses. And if they were to right size these markets the way they probably should be and regulate them logically, other than what we're doing, and not regulate, but the legislation dictates the regulation on. But if you had a logical approach to both, then without a doubt they would issue more licenses and should. But you can't really do that today. It's the system is the system is broken. It was already a difficult operating environment 3 years ago. And what's happened with unregulated intoxicating hemp in those 3-year period. And really, when no legislation was passed in 2023, which is an excellent lobbying effort on the hemp side, but when no legislation was passed with common sense regulation for hemp in 2023, then it took off like wildfire. So since 23, we've seen a massive escalation in licensing in unlicensed products, just frankly, washing over Texas and our schools. You're seeing this pop up in every school district in the state right now as a major issue. This is not us, hair on fire. It's when you have 7,000 licenses and probably 20,000 operators. Yeah, the majority are going to be good actors that are trying to operate within intent and letter of the law. It's the minority that end up running the
Dominating the market.
viewpoint of the market.
Yeah.
It's the minority bad actors that label all of the hemp industry. And you see it everywhere now. I mean, you saw it in Dallas, right? With Sheriff Dye,
Yeah.
raiding a whole number in Allen, right? Sorry. Raiding a whole number of stores. And people are saying, well, they had C of A's. And you know what? A C of A is not worth anything if you can't verify the C of A and test the product yourself.
Right.
Because who's liable for selling that product if it comes up hot, if it comes up contaminated with this aspergillus, which we've seen on our test of hemp product, if it comes back hot for pesticides and heavy metals, who's liable for that?
Yeah. And I'm going to tweak a little bit what Nico just said. The original session law in 2015 directed DPS to license at least 3 or enough for reasonable statewide access. That phrase, reasonable statewide access. The 12 number comes not from the law, but from the regulatory analysis DPS did to try to determine what that number should be for reasonable statewide access. And the number they came up with was 12. But then they only licensed 3, which is not at all their doing. That came from other pressures. But it's a big state. And if we're looking at what meets public demand for cannabis products, we can look at the number of hemp storefronts there are in the state, which probably is 20,000.
And I would say the issue here and the caveat to that is if you issue 20 licenses today under these regs,
Then
good luck.
good luck.
Good luck trying to fund
Right.
the CapEx required to build out what we've built out in the past.
Yep.
Can't do it.
Absolutely.
You're going to raise $20 million for 20 licenses. It's just not going to happen. Per license is basically what would be required to build out what these things are.
Plus the fees of hundreds of thousands of dollars.
Right. And we're 7 years into this in a cash flow negative industry because the market never materialized.
Yeah.
And then the market did materialize in a very big way in a completely unregulated fashion all around us. And the only thing that our license has gotten us is an inability to participate
In that market.
in that market. So that's the wild part.
So that you have to pay annually every other year, monster fees. I know from the other side of the world, the hemp side, those fees they're paying, for their growing and also they do there. I know that money's going nowhere towards the program.
There's no money. It's a couple $100.
Yeah.
You can't run a program on that. You can't pay salaries. Yeah.
If none of it's even getting back even close to it.
No, it's going back to dishes to run the program. But
Just the state fees.
Yeah.
There's just fees and there's the permit fees, lot permits and all that. License.
The TDA
They have
fees.
2 people that run the program at the state.
6.
There's
There's 6 investigations.
They make it to the state to help the program.
Yeah, absolutely.
Yeah.
No, I mean, they're in our facilities every month. They're testing our products. They have, chemists that work with us. Yeah. Dishes. No.
Explain a little bit. The fees they pay, usually fees to their patient agency usually stay within that agency to fund that particular program. So the hundreds of thousands of dollars they're paying goes to DPS. TDA gets the producers, the handlers, the lab fees, also the transport manifest fees for hemp products. Those are 100 here, 100 there.
Yeah.
Dishes gets the fees for manufacturers and retail.
They're actually staying in an organization or
They should be staying with that organization to fund the cost, and they now are up to at least 12 inspectors at Dishes, recently up from 6, or they were trying to hire up to another 6 last I heard.
Last year, one panel I was to listen to, they were saying that the money was coming in, but it wasn't being applied to the hemp program.
No, there's no money. There's no money there.
irrelevant, yeah.
It's irrelevant. That's a rounding error, right? It's not enough. If you think about what it takes to regulate this industry,
Yeah.
it's vertically integrated. It takes a lot. You have to test, you have to spot check product, you have to, combat diversion, all these things. If you think about what it costs, for DPS probably, frankly, doesn't have enough of a budget.
No.
Even to regulate us, and we're paying, whatever it is, $400,000 every other year, times 3 plus $500 for every employee every single year. It's a couple $1 million, right? But think of it on a per license basis. It means that a minimum per license, you probably need about $300,000 or $400,000 a year per license to regulate appropriately. And what the hemp industry is doing is like $100 per license. You can't do it.
So
It's
even
not
if that
possible.
$100 or $200 is staying with dishes and with the program to oversee the hemp industry, it's a drop in the bucket. I mean,
Yeah.
Susan
It doesn't
mentioned,
even pay one lab fee.
Right.
yeah, Susan
Yeah.
mentioned they're looking to expand to 12 people. But again, we're
And
talking,
there has been language.
About $60.
Yeah.
12 regulators with 7,000, licensees. So
It's irrelevant. The system was not set up to be it was never intended to be a broad-based recreational market. That wasn't what was supposed to happen.
that's right.
And they let this thing go and did not understand what they were doing. And now they have to figure out how they're going to put the cat back in the bag. Because if you want it to be a recreational market, if that's what people want, then you have to plan for that and you have to regulate for that. And that means you have to have in-state labs that are regulated in-state. And the licenses have to pay for the test to get done.
Yeah.
The dishes in California, the regulator doesn't pay for the tests for marijuana testing. The licenses pay for the tests, right? And so when we hear these stories, and there was a great news story, it wasn't the Sheriff Dye one, but it was another bust that happened recently. And they said, well, were you testing their products? And no, I have a C of A. I'm not going to test that. It's too expensive to test the product before I sell it. What?
Yep. Right.
I mean,
And
do they not understand the civil liability of that? That's
how-
bonkers. I mean, it's just bonkers to me. But
And I know we're out of time, but speaking exactly of that. So COAs, they can be run at any point of the process of growing that plant, right? Not just after product, after market. It's done sometimes on the plant itself, right? To see what it is. I had a friend in Virginia, hemp market. He was a farmer. He had to do COAs on his products before he sold them. So that everyone knew that it was hemp, right? And then he sold his hemp, dry flower. He then looked to see what was being produced from his products. Guess what COA was on there?
his own
His.
hemp one.
That's right.
That was the plant. That was not what they made out of that.
Yep.
But
Yeah.
they included his COA because he had done the testing already. So you don't know where the COA was done along the way.
That kind of regulation for it. You-
And
yeah.
I'll add what's
Also part of my product.
yeah, but again,
But
this is
particularly-
when we go back to letter of law versus intent of law. And that is not the intent.
right. All right.
So we can all operate, we can operate in loopholes, but we don't. Why? Because there's a real risk. If we start operating in loopholes, they pull our license.
Yeah.
So we have a vested interest in seeing this program through. When you have 7,000 licenses, there's no interest in keeping that license. No one cares.
And we're way out of time, but I'll add one thing to that. One thing that is in the hemp law that it has surprised me it has not been used by law enforcement is knowingly using an altered COA is a felony.
Yeah.
An altered COA.
Yeah. And any good defense lawyer could, I'm sure, make the argument of why it wouldn't apply with someone using a sketchy out-of-state COA for the plant when they're selling the gummy or whatever. But I think that's a lot of what's happening in the market now, as you pointed out.
Heather's throwing stuff at me to.
Yeah, Heather's like,
So-
I think they're staying.